Hi, my name is Deanna Kepka. I'm an investigator at Huntsman Cancer Institute. I'm also a professor at the College of Nursing at the University of Utah. I work mainly in HPV vaccination. So I'm here to talk about vaccines, the solution, vaccine access and hesitancy, the challenge. So I do have one conflict of interest that I'd like to report. I'd like to disclose that I receive a small portion of my salary from American Cancer Society, and they receive a larger grant from Merck that supports that salary. So my main deal is HPV vaccination. And in the US, HPV infection is incredibly common. It is the most common sexually transmitted infection in the world and in the United States. 1 in 4 of us sexually active adults have HPV right now. 80% of us will have it at some point in our lives. But most of us clear this infection from 6 months to 2 years and do not have any long-term effects from it. However, those of us who don't may develop abnormal pap tests. That's 1 in 5 to 1 in 10 women have an abnormal pap test or a positive HPV test. And among those precancers, they may lead to cancer. So if we had adequate HPV vaccination in the United States, we could prevent 34,000 cancers each year. Now, when you think about HPV cancers, what are the most common cancers that you think of? And just think about it in your head. What's the most common HPV cancers that you know of? So you may be thinking that cervical is the most common HPV cancer in the United States. It's actually oropharyngeal cancer, cancer of the back of the throat. And it is most commonly occurs in men, white men. So it's contrary to what we typically think about HPV vaccine. We think, oh, it's protecting against cervical cancer in women. That's the main deal. But it's actually also protecting against oropharyngeal, anal, and penile cancer in men, along with vaginal and vulval cancer, along with anal and oropharyngeal cancer and cervix in women. And when you think about vaccination, HPV vaccination, if we got it up to where it should be, which is 80% of our kids vaccinated by age 13, we could prevent over 90% of cervical cancers and those other HPV-related cancers. And the thing about is we have 11,000 cases of cervical cancer each year in the US, but that's just the tip of the iceberg. The HPV vaccine would prevent 200,000 cases of precancers, which are indicated by abnormal pap tests and positive HPV tests, and can relate to risk for pregnancy and other sociological, psychological, economic, and additional burdens that women and their families face when facing abnormal pap tests and related treatment for those precancers. All of this could be prevented by this vaccine. And that's why I'm going to dig a little bit deeper into HPV vaccination. Well, we've got some challenges in the United States around HPV vaccination, and then we went through this 2-year pandemic going on 3 years. And with that pandemic, we had the largest drop in vaccination rates among adolescents. Adolescents were the least likely to go in for their well child visits during the pandemic. As a result, in the country, in the United States, we have an 18% drop in HPV vaccinations, along with Tdap and meningococcal or Menactra. So we've got to get these kids back in for their primary care visits, and we've got to catch them up on HPV vaccination. This is the platform, the adolescent platform. We know starting at age 9 is a really effective strategy for bumping up HPV vaccination. And those are American Cancer Society's primary recommendations right now. Start at age 9 and 10 for the first dose of HPV. It's long before puberty. Parents are more accepting of the vaccine, and then get their second dose when they come in for their well child visit 1 year later. But if you don't wait, if parents are like, oh, my kid's not ready, they're not sexually active, you know what? The vaccine will not be as beneficial waiting till a later age, because the immune system is most responsive at that younger age. And furthermore, if you get to age 15, when you start the HPV series, now you need 3 doses. So you go from a 2-dose series to a 3-dose series, which is just incredibly burdensome for busy families. Furthermore, if you wait before age 15 and ideally get it before 13, starting at 9, you can get that 2-dose series 12 months apart. If you don't wait until 15, you need 3 doses within 6 months to be compliant. How are we doing in the West in terms of HPV vaccination? Well, we've got a long ways to go. I like to call us the sea of light blue, the sea of white that I've been really addressing for the last 10 years of my career at the University of Utah. We've got a lot of barriers to HPV vaccination in the Mountain West region, and specifically in the state of Utah. So if you look at this map of the United States, when people ask me, what's the #1 factor that relates to whether or not a child received the HPV vaccine? Let me tell you, the #1 factor is where you live. If you live in the Northeast, Rhode Island, 95% of those kids are HPV vaccinated. If you live in the West or Mississippi, South Carolina, Virginia, West Virginia, you're much, much less likely. In most of those states, less than half the kids are up to date with HPV vaccination by age 17. And then the patterns of vaccine hesitancy have been pretty similar for the COVID-19 vaccine. You look at similar patterns of lower performing states being in the South and in the West for COVID-19 vaccine. So that's telling me that vaccine hesitancy is a social construct that can relate to many, many different types of vaccines and for a variety of age groups within the context of what's happening at our society at the time. When we look at how states are doing for 1 dose, Utah is 46 in the country. That means there's only like a handful of states worse than us for our kids getting the first dose of the HPV vaccine by the time that they're 17. And I know for a fact that if you look at completion of this series, Utah is even lower. I think we're the 50th or 51st state for completion of the multi-dose series. And then another factor I'd like to bring up is rural-urban disparities. So if you look in the green, that's living in an urban area, metropolitan statistical area, compared to the turquoise. The turquoise is living in a non-MSA, that's a rural community. And time again, we see lower HPV vaccination rates and lower completion rates for children who are living in rural settings across the United States. And this is especially problematic because often we see higher rates of cervical cancer and cervical cancer mortality and other HPV-related cancers in rural settings than in urban settings. And that's often due to access to healthcare and Pap testing and follow-up procedures. So I already got into why this is happening, but some other thoughts are, there's many, many layers of barriers that rural communities face in the Mountain West that it could impact HPV vaccination. Some of them could be cultural views, but other points could be, sometimes parents are driving an hour to 2 hours to get to a rural healthcare provider or a rural county health department that offers vaccines. So vaccine distribution access can be a challenge. Often electronic health records aren't always syncing with the vaccine registry in rural settings. They haven't developed that level of sophistication for vaccine tracking. Missed opportunities for vaccines. Kids are coming in for their Tdap and Menactra, they're required for school, but they're not being recommended for HPV when they're already there in their office. Provider shortages. We know we have a shortage of primary care providers in rural settings in the United States. And clinical constraints. You may have longer appointment wait times in rural settings because of those provider shortages, and it may be difficult to come back for that second or third dose. We also know that fewer evidence-based HPV vaccination interventions have been tested in rural settings in the United States. So what are some evidence-based strategies or factors related to improving HPV vaccination that we should be exploring and implementing in the Mountain West? Well, when I think about HPV vaccine hesitancy, I can't help but think about this overall vaccine hesitancy model. Where is this hesitancy coming from? Some of it is confidence in our healthcare systems, in our government, in the Centers for Disease Control and Prevention, guideline-making institutions, trusting in their recommendations. Other factors are complacency. You know, if I get COVID, it's not really that bad. From, you know, people get better. It's like the flu. You know, so that's being complacent, not prioritizing that it's that big of a deal. Another issue is convenience. You know, if you have to go for a multi-dose vaccine and you live in a rural setting, that can be very inconvenient. Calculating how much information gathering are people doing related to their vaccine choices for themselves and their children, and what is their willingness to protect others. So maybe I think, oh, if I get COVID, I'll clear it and it won't be a major problem. But what about my social responsibility for grandparents, for persons who are immunocompromised, for people who are in more vulnerable situations than myself in terms of their health? What is my collective response in terms of my duty to be protected so I don't spread a virus and affect others? All of these factors influence vaccine decisions. So we know evidence-based strategies that work for HPV vaccination are increasing access, making HPV vaccine more available in a variety of different settings. And maybe that could be expanding HPV vaccine access to more pharmacies or to dental practices, or getting in at every school, have vaccine immunization days in schools that really emphasize the importance of this cancer prevention vaccine. Treating every visit as a vaccination visit. So if a kid comes in with an ear infection or a sore throat, that's an opportunity to vaccinate. You don't want to let them leave your office. You don't know when you'll see them again. Treat every visit as a vaccination visit. Prompt the healthcare provider with EHR systems, with healthcare teams, reminding providers that every visit that a kid comes in, keep them up to date on the vaccines that kid is eligible for and encourage that strong recommendation to get it. We know the number one most effective factor that relates to whether or not a child receives the HPV vaccine is, do they get that strong recommendation from their healthcare provider? Whether that key healthcare provider is a nurse, a physician assistant, a physician, is that provider telling them, yes, today you're getting Tdap, HPV, and meningococcal vaccines. Let's throw in COVID and flu. They're going to happen in 10 minutes. That's what's happening. And present each of these recommended vaccines in the same way and give them on the same day as you would other vaccines. Really emphasizes they're all recommended. They're all important vaccines for your child's health. And then you need to track series completion and follow-up to measure and improve performance. So we did a survey during COVID that looked at vaccine hesitancy among young adults in the Mountain West. We surveyed about 3,000 young adults, mostly women participated, but we have some representation from males and other genders, a variety of ages, but most of them were younger, to between 18 to 21. We captured the whole West in our sample, but had an oversample of Utah participants. We also oversampled rural participants, 40% rural. And we really found that our rural participants were more likely to be vaccine hesitant, not thinking that they were necessarily a good way to protect from disease, not necessarily agreeing that they're safe, and not necessarily agreeing that they're safe and as effective as often as urban participants would. And we also saw similar factors when we looked at, how important are vaccines to them for protection. We saw our urban participants having a much stronger advocacy for vaccines than our urban participants having more support for vaccines than our rural participants across every single component in terms of believing that they prevent disease, believing that they work, and trusting their provider recommendations. But we looked overall, who do people want to get their recommendations from? The number one indicator across 70% of our survey respondents of that 3,000 sample was they want to hear from their physician. And 51% want to hear from their provider, and about 2/3 want to hear from their health authorities. Not as many want to hear from government in terms of vaccinations. So this just highlights the points that I was already making, that Young adults living in rural areas had a 40% less odds of intending to receive the COVID-19 vaccine compared to urban. So we just saw a much higher rate of hesitancy in rural, and it also related to HPV. So young adults who had received an HPV vaccine were 1.8 times more likely to intend to receive a COVID vaccine. So we see a similar patterns across both vaccines, pro-HPV, pro-COVID, not pro or supportive of receiving HPV, not as likely to intend to get the COVID vaccine. Lastly, I just want to talk about, we have a Mountain West HPV Vaccination Coalition at Huntsman. We work across disciplines. We'd love for you to participate in our coalition. Get in touch with me if you want to join our activities. We have monthly webinars, in-person meetings soon, now that we're getting post-COVID once a year. And this is my son getting his full adolescent bundle of HPV, Tdap, and meningococcal last summer during the COVID pandemic. He was a true sport to having a professional photographer there. So I'm really proud of him to be able to not only get this cancer prevention vaccine, but also to demonstrate his courage in this huge social media campaign. Feel free to get in touch with me. I'm happy to answer any questions. Thank you so much for your time.